Good evening, everybody. We'll get started in a minute or two. We're just going to let everybody join the webinar, but we are recording. All right. It looks like we have just about everybody joined now. So good evening. It is my pleasure to welcome you to tonight's webinar on the Fall Respiratory Illness Vaccine Campaign. For those I've not met before, my name is Britt Corral, and I'm the Pharmacy Practice Advisor with Pharmacists Manitoba. We also have on the call this evening Andrea Lear, the CEO of Pharmacists Manitoba, Jill L., who is our COO, and our newest staff member, Kim Longstreet. Tonight's presentation is being recorded, and the link will be made available on our website, accessible to Pharmacists Manitoba members and non-members. We will also be sharing a link to this presentation in our weekly script shortly, so keep your eyes open for that. If anyone is interested in having a PDF copy of the slides, we can share those upon request. Please send an email to info@pharmacistmb.ca if you'd like a copy of those. After the presentation, I encourage you to type your questions into the chat feature. And now I'd like to turn the meeting over to Inga Hossack, who will introduce our speakers for tonight. Inga is the manager with the Policy and Operations team in the Immunization and Inventory Department within the Communicable Disease Control section of Manitoba Health's Population and Public Health Department. Inga's team will also deliver tonight's land acknowledgement. We appreciate you joining us, and we hope that you find tonight's presentation helpful as we work towards increasing access and delivery of vaccines to all Manitobans. Inga, the floor is yours.
Thank you, Jill. Thank you, everybody, for attending. This is awesome. So our team here consists of myself, also Dr. Davinder Singh, who is our medical lead and a medical officer of health within Manitoba Health. We have Dr. Jazz Atwal, who is our Deputy Chief Provincial Public Health Officer for the province, as well as Dr. Richard Baydack, who is our Executive Director at the Communicable Disease Prevention and Control Branch. And we have Stacey Bullitt, who is also part of, she's our PHIMS guru person who will be presenting on the PHIMS portion of the presentation. If you want to go to the next slide, please. So we acknowledge that we are gathered on Treaty 1 territory and that Manitoba is located on the treaty territories and ancestral lands of the Anishinaabe, Anishinaabeg, Dakota Oete, Dene Sulene, and Nihanoak nations. We acknowledge that Manitoba is located on the homeland of the Red River Métis. We acknowledge that northern Manitoba includes lands that were and are the ancestral lands of Inuit. We respect the spirit and intent of treaties and remain committed to working in partnership with First Nations, Inuit, and Métis people as we walk the shared path of truth and reconciliation. All right. I will pass it over now to Dr. Davinder Singh.
Great, thanks, Inga. So just to start us off, I just thought we'd look at what we can glean from the Southern Hemisphere, just to try to see what they experienced, as that's at least potentially some indication of what could occur in the Northern Hemisphere. Obviously, with not a direct correlation there, but in Australia and South America, they had a predominantly H1N1 season, so typically, you'd think of higher impact in younger populations. They also had similar numbers of influenza-like illness, influenza positivity, COVID, and RSV positivity in this respiratory virus season compared to the 2024 season that they had, although there were slightly lower numbers this year. And same kind of situation in South America, although if the one kind of standout thing about South America was they had really low numbers of COVID in 2025 compared to 2024. So, that was particularly unusual, but, COVID is still so relatively new with us that I think that it's still not entirely predictable. So we'll still kind of continue to see changes as things evolve with the epidemiology in COVID. Next slide. This is just the graphs of what I was saying for Australia. Sorry if they're small, but you can see just for the top left figure that RSV numbers quite similar this year compared to 2024. COVID numbers, you have to magnify them compared to the early part of the pandemic to see. And overall, they had very similar numbers in Australia for this year compared to last year. And then the bottom left, we've got influenza. And if you look at kind of the 2025 curve, that's still, only partially for the year. It was, relatively quite similar to 2024, just, a bit lower activity. So overall, quite similar. Next slide. And then same with South America. So these are overall number of positive samples as well as percent positivity for the three respiratory viruses that I've been talking about. And if you look at the curves for influenza, RSV positivity, and COVID positivity, then again, quite similar this year compared to last year, with again, the exception for COVID positivity overall being a lot lower in 2025 than 2024. Next slide. Over to you, Dr. Atwal.
Thanks for that. Again, thanks for having us here. So again, I'm Jas Atwal, Deputy Chief Provincial Public Health Officer. I'm just going to review some of the clinical reviews that were done related to vaccine uptake. So we've been kind of monitoring the situation the past several years in relation to vaccine uptake, and also, the risk that it had posed from a influenza and COVID perspective on the acute care system. So the 5-year trend, both influenza and COVID vaccine uptake continue to decline. You could see this in the 1 to 4 age group there, dating back to 2019 to last year. On the senior side, 65 plus, you could see a slight decline as well, maybe a bit of an uptake because of COVID and the mass immunization programs that happened there. And now we're kind of back to that baseline prior to 2020. Next slide. This is the weekly respiratory related emergency department visit. So this information we get in real time on a week-to-week basis. And you could see sort of that influx of clients presenting with respiratory-like symptoms to emergency departments in Manitoba. And you could see, the peaks and valleys there. And really, this is an issue for 3 to 4 months time in duration, usually a significant peak, then it drops off, and then usually a secondary peak there afterwards as well. So this gives us, that opportunity to vaccinate a large proportion of the population prior to illness developing, where they require, let's say, a physician's visit or a hospital bed or even an ICU stay as well. Next slide. So manually, what we did, and we did this last year, and we actually did this the year before as well, but we're just going to present last year's data. From November 3rd to March 8th, so 126 days, we had 38 total admissions for COVID and flu into the ICUs. And these were confirmed through review to be a true admission related to that illness as well into the ICU. The vast majority of these individuals were not vaccinated. Only 6 were vaccinated for flu only, and of those, 4 also had the COVID-19 vaccine. Most clients who were admitted into the ICU had diseases such as diabetes, chronic kidney disease, COPD, high blood pressure, and coronary artery disease. And most who were unvaccinated had opportunities to get immunized through a physician, pharmacy, or health system, emergency room, surgical day procedure where they got scopes, even dialysis. And we're saying that they had opportunities because according to the reviews that were done, they filled a prescription. they had a test done, they were admitted to the hospital, they saw a physician as well. So that's some of the administrative data that we looked at to determine this. Whether they were offered vaccine, we don't know. We weren't able to go into the charts to review that specifically. But again, the vast majority had that opportunity, have an interaction with a healthcare provider, and for whatever reason, they were not vaccinated. Also, after reviewing the data and in the past couple of seasons, the findings are similar. Certain conditions such as poorly optimized diabetes, so patients with elevated A1Cs higher than 9, higher than 10, were found in the ICU. So diseases, chronic diseases that aren't well controlled, and also diseases where fluid balance is an issue. Look at congestive heart failure, you look at chronic renal disease and chronic liver disease as well. Next slide. So our key goals from a public health perspective, from a system perspective, I think from a Manitoba perspective, is to reduce severe outcomes from influenza, COVID, and RSV. We want to immunize those that are highest risk of severe disease. So that includes Indigenous Manitobans, individuals with underlying medical conditions, those 65 plus, and those in long-term care facilities, pregnant women, and infants and children between 6 months and 4 years. So we want to optimize vaccine use to minimize wastage. We want to optimize vaccine uptake prior to that season starting as well to help mitigate some of these issues that we see on a year-to-year basis. And this isn't just in the last 5 years. Prior to COVID, the system had similar findings as well. So that those issues that we see from influenza typically happen every year. System is preparing for it. The system has been working year to year to prepare for the influx of clients. And on the vaccination side, we've been expanding, who provides vaccine, looking at opportunities and really targeting and trying to target those individuals at our greatest risk as well. Next slide. I believe this goes to Richard, right?
Yeah, I'll jump in. Thanks, everyone. I'll just note I had a moment of technical difficulties for a couple of minutes ago, so hopefully those are over with. But in case I get knocked out of the call here, Inga, I'll ask you to jump in if necessary. Okay, so I wanted to talk a little bit more, first of all, about the 24-25 season. So during the 24-25 season, we had approximately 23.5% of the population who received flu vaccines and a little more than 16% who received COVID-19 vaccines. Those rates were significantly higher in Manitobans aged 65 plus at about 59% for flu and about 50% for COVID. But those are still decreases compared to the 23-24 season. Last year, we did have 1,007 unique healthcare provider locations who registered to participate in our flu and COVID immunization program. And we shipped nearly 1 million doses of flu and COVID-19 vaccines across Manitoba. And there were about 5,100 orders that were processed during the season. The respiratory virus season did start much later than normal, with high volumes of cases only appearing in February and March. Next slide, please. So next, I wanted to review the eligibility for our programs. So starting with flu and COVID, all Manitobans aged 6 months and up are eligible to receive those vaccines free of charge. For pneumococcal vaccines, so Pneumo C20, all Manitobans aged 65 plus who have not previously been immunized with either Pneumo P23, that's the old vaccine for the program, or Pneumo C20 since turning 65 are eligible for a dose. And we also have some eligibility for those who are at high risk of invasive pneumococcal disease. The details of that high risk eligibility you can find on our vaccine eligibility website. Currently, I want to note there's no recommendation to administer another dose of Pneumo C20 if someone has already received a dose. Moving on to RSV for older adults, our eligibility is that individuals aged 60 years and up are eligible for 1 dose of the RSV vaccine if they reside in a personal care home or if they've been admitted to a PCH for respite care, or if they have been admitted to a transitional care unit and have been paneled for PCH and are awaiting placement, or if they've been admitted to a chronic care unit and have been paneled for PCH. In terms of timing, we know that 2 weeks are needed for an optimal immune response to the vaccine. So we do encourage providers to begin immunizing as soon as you receive product and have it available to offer to clients. Next slide, please. So just a little bit about the program setup. So hopefully most, if not everyone who's listening today has already been registered, but if not, it's pretty simple to do. First, it's necessary to review the requirements. And these are, you can find these at the first link on the page on the left-hand side. Then you can register for the program using the form available at the second link. And as part of that process, you have to agree to all the program requirements in order to register. And finally, we're asking that you return any expired or unused vaccines to MDA. You can review the biologics return policy and procedure available at the third link on the left-hand side. In terms of providers for this year, they're again divided among 3 distribution groups. So the first is the priority locations, consisting of hospitals, First Nation communities, and long-term care facilities. And then all of the other providers are divided into groups 1 or 2, depending on the last digit of their holding point codes. So group 1 this year will be those ending in 0 to 4, and group 2 will be those with holding point codes ending in 5 to 9. Next slide, please. We will be using online surveys once again to allow providers to request vaccines or to order vaccines. Those surveys will be emailed to the contacts that you have identified during the registration process. When you're filling out a survey, we'd like you to make sure to use the correct holding point code, that's the 5-digit code, as well as the correct email address. If you do provide incorrect information, that could affect the ability to receive both the confirmation email and cause some challenges around the orders. I'm sure we'd get it figured out, but it would present a bit of a barrier. We are asking providers to order a 4-week supply on the initial survey. And that first survey we're calling it a pre-order survey. And that's because we don't currently have vaccine in stock and available to ship. So we're using this survey to plan and allocate orders based on the supply as it becomes available. Once we do have vaccine, those allocation emails will be sent out to advise you of the number of doses of each vaccine that you'll be receiving and when we expect to be able to ship them. I wanted to note that based on the pre-orders that we've received and reviewed to date, there have already been more doses of flu vaccine for those 65 plus ordered than were administered to that age group during all of last season. So I think we're continuing to see a trend of over-ordering by all providers on average. So that doesn't mean each provider is over-ordering, but that's the average trend. Moving on to sort of subsequent surveys after this initial one, the process will be similar to last year. Surveys will be sent out on Thursdays, and then we'll close 5 days later at the end of the day on that following Tuesday. And then shipments will occur during the week after the survey closes. Priority location orders will be fulfilled first. And for non-priority locations for this initial survey, it's very likely that we will be splitting the vaccine order into 2 separate shipments, which you can expect to receive approximately 2 weeks apart. And this is based on the schedule on which we receive vaccine from the manufacturers. And you'll hear a little more about that in the coming slides. Next slide, please. Okay, so this is just a little bit of a reminder that we don't receive all of our vaccine at once prior to starting to ship it out to providers. So We do receive the federal allocations of flu vaccines in approximately 4 deliveries. You can see the timelines. These are the contractual obligations within the national contracts. So we're meant to receive about 43% of the flu vaccine by September 22nd, 71% by October 1st, a little more than that a week later, and then our full complement of flu vaccines by mid-October. And that's why we can't ship out full orders, 4 weeks of vaccine beginning in September when we haven't received it all yet from the manufacturers. And a final note on this slide is just that the percentages and the delivery dates are tentative and subject to change based on manufacturer supply volumes and schedules. Next slide, please. Okay, so a little bit more about deliveries. Priority locations, like last year, will have access to weekly deliveries, and groups 1 and 2 will have access to bi-weekly deliveries at the beginning of the program. Later in the season, as demand begins to slow, perhaps in November, December, we may, as we have in the past, use an open-ended survey where all providers can order as needed. Once you receive product at your location, we'd like you to go ahead and start immunizing as soon as possible. But we also want to remind you not to book appointments until after the last date of the delivery window that is communicated to you in the confirmation email that you receive. So just as an example, if you receive an allocation email that says you will receive X number of doses of each of these vaccines, and they should arrive between October 1st and October 5th, then the earliest we would want you to start booking appointments is October 6th to make sure that you're guaranteed to have that vaccine. Now, if subsequently you actually receive the product on October 2nd, well, then you could go ahead and start filling in those earlier appointments. But we just want to make sure that the vaccine will be on hand before those appointments are booked. Next slide, please. Okay, in terms of when we expect to get vaccine out initially, again, I have to review the fact that the delivery schedule is dependent on the vaccine manufacturers meeting their obligations, and it is subject to change. But currently, if all goes according to plan, we do expect to begin shipping to priority locations and Group 1 during the week of September 22nd, and then to Group 2 during the week of September 29th. For a little bit of national context, we wanted to also mention that many jurisdictions in Canada start the program by distributing and offering the vaccines to priority locations like hospitals, personal care homes, and First Nation communities for the initial couple of weeks in October. And it's only once those priority locations have received their vaccine and started immunizing, then the program opens up to the general population during the second half of October in many provinces and territories. So that's, I think, a bit of a contrast to what we're trying to do, which is to really get vaccine out to as many provider locations as possible to provide early access across the province to anyone who would like to receive these vaccines. So on that, just a final note is that, we've seen that our immunization rates aren't where we want them to be with these programs. And so we would really encourage all providers to be less concerned about whether the location down the street might receive vaccine a little bit earlier. That's really not the issue. The issue is how can we get more people to choose to be immunized with these vaccines. Okay, next slide, and that's over to you, Inga.
Thanks. Okay, so I'm going to start going over the various different products that we have, or we're going to have. So as to start, changes to the recommendations on the strains included in the flu vaccines. The manufacturers have moved to all products available in Canada to being trivalent vaccines this year. As you can see, we have several vaccines that are received in Manitoba. And that's again based on the allotment through the national contracts. I've identified here just some of the couple of new products that we are seeing or that we are experiencing here in Manitoba. Flu viral, we have used it previously, but it's been a few years, so we kind of considered it to identify it as a new. Flu Cellvax is one Manitoba has not had before, and it's a cell-based vaccine, so it's not made in eggs. So that's a new one for us. All these products can be used in those 6 months of age and older. So there's no preference for one product over another in that grouping. For those 65 years of age and older, we have two products this year, so Fluad and Fluzone High Dose. And as many know, Fluzone High Dose is the one that's been used in Manitoba for over the past several years. We'll go into how we're going to manage that right away. And just so you know, the supply will be allocated to providers based on what is available on hand. So we can't really, if you're wanting Fluzone prefilled syringe, it all going to depend on what we have in supply at the time. So it really is depending on a lot of different factors. Next slide, please. Okay, so the Fluzone High Dose and Fluad eligibility, it is extremely important to be able to follow this eligibility criteria. So we understand it's going to might cause some added complexity to managing products within the locations, but we only have so much product of each, and so this is in order for us to manage it appropriately. I had to identify this eligibility. So for community dwelling individuals aged 65 to 69, it will be just Fluad. And then the Fluzone High Dose is going to be used for adults 65 and older who are at highest risk of severe outcomes. So residents of long-term care, supported and assisted living facilities, transitional care beds, Indigenous Manitobans, home care services, living in remote or isolated communities or north of the 53rd parallel, and correctional facilities, and then as well, community dwelling individuals 80 years of age and older. So I know it sounds complicated. So for locations like such pharmacies that are north of the 53rd, you're not going to have to worry about anything. You'll automatically be allocated the Fluzone High Dose. So that you'll probably see some of those questions that had come up of, are you in the 53rd parallel? So those are the reasons for those questions. And then it's just essentially making sure that all the other pharmacies, all the other locations really just kind of base it on age with regards to the two products. And most of the others are, and then obviously Indigenous Manitobans, regardless of residence. So there's pharmacies really have a very, limited to be able to determine if they're community dwelling based on their age. And then the Indigenous Manitobans would be the other factor. However, if you have a client who's 65 years of age and older and is interested in immunization, but you don't have the product that matches their eligibility, you can still offer them another product. So either the other enhanced product or a standard dose. But you should really discuss that with the client before administering. So if all you have is a standard dose, but they really want the enhanced product, have those discussions and whether they should just continue to get the standard dose or potentially someplace else might have that product that might be appropriate for them. Next slide, please. So going back to the order surveys, so due to our limited supply of each of the enhanced vaccines for seniors, there are questions that are on the surveys that will help us at Manitoba Health with the allocation of the product. So again, it's based on facility type, location, population specific needs. So that's those type of questions are helping us to allocate appropriately, or hoping or trying to allocate appropriately. So it is asked to make sure that if you can respond to the questions as appropriately as possible based on the knowledge that you do have of your clientele, that would be it helps us a lot. And then our allocations, are based on those answers that you're providing. So you can, then next slide, please. All right, COVID products. So nationally, there's only mRNA COVID vaccines that will be available as part of the publicly funded programs. The non-mRNA products, so this was Novavax, did not participate in the national contracting process, and I believe they've even changed companies. So we really don't know if they're going to be making the product available in the private market or for purchase or not, but no Canadian jurisdiction has it as part of their these national contracts or publicly funded programs. As a result of the national contracts that have been awarded, so providers will need to be aware of the age of their client to ensure the correct product is used. As you can see, there's quite a few things that are available, but there will be some pre-filled syringes and single-dose vials, which will help reduce a lot of that wastage that we know is out there. So supply is going to be allocated based on what is available and may be dependent on location. We are going to try to kind of allocate, so for example, public health offices who are doing mass clinics, for them to have multi-dose vials makes sense because they can just go quickly with them. But other locations, it might be warranted to have more of the pre-filled syringes. So we're trying to balance that, and also maybe multi-dose vial at the beginning versus when the demand slows down and we want to reduce some of that wastage, then the pre-filled syringes. So we're kind of working and looking at the different options that are available. Moderna, for example, can be used. Nope, sorry, go back. Thanks. Moderna can be used for all ages. So that's still the same. However, their multi-dose vial should only be used for those under the age, or not should, I guess it can be used for those under the age of 12, since the dosing is different as a half dose, because we can't split, do a half dose with a pre-filled syringe. So the Moderna multi-dose vial is also the only product available for those under the age of 5. So again, that is extremely important for how to manage the product and your inventory is around that. For example, yeah, the Moderna multi-dose vial for 6 months to 5 years is really, you need to be able to kind of reserve it for that type of idea. Pfizer continues, for whatever reason, to have different products for the different age groups. So there will be the product for 12 plus that will come in the multi-dose vial and pre-filled syringe. As you can see, the pre-filled syringe has a longer expiry date of 8 months, which is absolutely fantastic. And then there will also be the Pfizer pediatric that is to be used for those 5 to 12 years of age. So that particular one, it still, it still shows it like that's the age that you can only use it for. So to ensure supply is available for the appropriate ages, just please make sure to use the correct one. So whether it's downloading this table, whatever it is, we have some other documents available for you to use. And just to kind of, I'm sure once it all comes together, it'll be all good too. So next slide, please. All right. So just to kind of go over the cold chain requirements, which is standard for us to deal with. It's the flu and COVID vaccines are going to be shipped and delivered to providers in a refrigerated state. So we still have providers who feel that they need to refreeze it, and we cannot do that. So a reminder that it should just be refrigerated once received. As you saw, there's different limitations on how the timelines for storage for pre and post puncture. So those need to be followed, and you can go to the product monographs for that, or you can use a quick reference guide that we've created that is available online at the link. And over to Dr. Atwal for the next couple slides. You're on mute.
Sorry about that. So what we're doing is, we just had a town hall earlier today with Docs Manitoba, and obviously we're having one with pharmacists now. We really want to push the idea of, making sure that every interaction is maximized with the client. So we're asking pharmacists to offer both flu and COVID-19 vaccines to clients at every visit, especially to those at higher risk in children aged 2 and 5. So in 2024 and 2025, there's a slight increase in the number of doses administered by pharmacists to those in the younger group. And that's a great thing to see. We want to continue to try to improve those numbers as well. And if some pharmacists are hesitant per se because they are younger, there are some additional opportunities for training that will be available as well. And we're looking to see if pharmacists can review the ways that they actively recommend and offer flu and COVID vaccines to clients as well. So, from using medications as proxies for certain conditions. You could highlight who is at higher risk, and if you're not able to offer everyone a vaccine coming in, maybe even just targeting those at higher risk is another opportunity as well. If someone's getting their medications once a month, if they said no the first time, sometimes when you ask the second time, it makes a difference. I work clinically, and sometimes people say no the first time. But when you see them the next time, you have another opportunity to build that rapport. They change their minds. Sometimes it's not 100%, but again, we want to try to maximize that opportunity to offer and provide that vaccine in real time. So if they do say yes, also, it's not, hey, come back tomorrow, that's when I'm going to do my vaccines. Just try to get it done in that real time, because typically patients don't tend to come back. We see the same thing with physicians' offices, and we're asking physicians and we're asking the healthcare system, the acute care system, to do the same thing as well. Next slide. So the next steps is, increase immunization access for families with children under 5 years of age. That's the lowest coverage rates in this population. To recommend those 65 plus get an enhanced influenza vaccine over the standard dose. So we talked about some of the options there. And then we want people to record all flu and COVID vaccines administered via PHIMS. To ensure that we're able to get that information in a timely manner, and that it is documented in a proper fashion as well. Next slide.
It's over back to me. Thanks, Dr. Atwal. All right. So as Dr. Atwal mentioned, additional training to try and increase that access and feeling people to be comfortable immunizing the younger children. So there was a survey that healthcare providers completed. About 40% of the participants reported not immunizing children under the age of 5 due to discomfort and insufficient training. So as a result of that, we have worked with, in partnership with Pharmacists Manitoba, to create a recommended, like a training module for pharmacists. So the goal is to enhance pharmacists' comfort and competence in immunizing young children, and then which would then, support increased vaccination coverage in this group. I would say that we have had, the past couple of years, a large amount of the public connecting with Manitoba Health, identifying that they really just don't have access for their children to get immunized, and it's a struggle. So I think, if we can increase, we know the value and the access that pharmacists have. So I hope that this training will help ease some of those that discomfort and increase the training for the providers. So I've identified at where the links are for the training, and definitely I hope we can get some pharmacists doing more of that age group. That'd be great. Next slide, please. So for the vaccine provider map, we are continuing to put anybody who's been registered, who's registered to receive the flu and COVID vaccines will be on the map. So new this year, when everyone registered and they identified that they were going to be doing, whether they're going to immunize the children of different ages, we are going to be identifying that on the it's like the info tab. When you click on a location, it tells them their name, phone number, their hours of operation, or their links that they have for their site. It'll state that information, whether they do immunize children. And there will also be a filter that the public would be able to select 6 months to 2 years, and then only those locations that have identified that they will be doing that population, it'll come up. So trying to make it a little bit easier on the public, and trying to show where the access is for those those families to be able to get their children immunized. Right. Resources. So We have a whole lot of resources that are available on our website, but we just want to highlight a few of them here. So our flu and COVID fact sheets have been updated, and they're already available online for printing for those who want to. They are also available in 15 different languages. So we really would like to encourage all providers to use these as much as possible to promote the vaccines. One thing we are in the process of doing, they're not available online yet, but it's a poster that has QR codes for each language. So they can be posted, that poster would be able to be posted, and someone can scan the QR code for that language that of their preference. So yeah, definitely we hope to use these fact sheets as much as possible to promote the vaccines. We would love for providers to do that. For providers that use consent forms, those are also available online now. So those have all been updated and ready to go. As mentioned before, we have quick reference guides and vaccine comparison tables that could be printed and used to help with the understanding and getting familiar with all the different products. So those are already online as well, ready to go. You can also order different posters and other resources, such as infection prevention and control posters. They are free of charge. We're hoping to get the campaign posters ready. If they do become available, they'll be printed, and hopefully, but they will be also online to be able to print. And then for those that administer to people without a FIN, that also can be, we can complete the reporting form and send those back to us to enter into the registry. I'm not sure. I seem to recall that pharmacists can also create and enter. So this might not all necessarily apply to you as well. And in the event you see an error in a client's immunization record, there's also a correction form that we encourage healthcare providers to use. Next slide. And this is just a quick side. I'm not sure how much the pharmacists are part of this, but testing and treatment resources. So, testing really should be done only for those at highest risk and when there is a need to know if it's COVID for treatment purposes. So we've put a bunch of links here around information on testing and treatment for COVID, and then also like the recommendations from Shared Health regarding COVID-19 treatment. The recommendations for influenza treatment is from the AMI guidelines, and those links are updated there. And then there's, you guys I'm sure are already aware, but the coverage for the COVID-19 Paxlovid and influenza, so the oseltamivir treatment, is also dependent on identified criteria in the drug formulary. So I'm sure you guys all know about that already. And then if you are looking to help provide assistance to your clients around managing respiratory infection symptoms, we have a guide there as well. So lots of resources that are available. And then I have my last slide is our resources around our surveillance report. So Manitoba has a surveillance report that is updated weekly that provides lots of information on COVID and flu and what is happening in Manitoba. So knowing the current information of what is happening could help to identify to your clients what is happening, how severe these infections are, and help in the recommendation to them around being immunized. And then the next slide is, I believe, going to PHIMS, which will be Stacy.
Good evening. I'm the manager of the Public Health Information Systems with Manitoba Health, and just here to refresh, remind, and update on all things PHIMS. So we can go to the next slide, please. These are all friendly reminders to ensure that all your information is up to date, that your Information Sharing Act agreement signatory is currently employed at your site. So with lots of ownership change, manager changes, you might want to ensure that it's still up to date. Including your account sponsors and requesters are up to date. I know the PHIMS team does do an annual audit, but sometimes people change in between. I have the link to the form here, as well as sending it to the service desk. And then lastly, ensuring you have the staff that you need, having PHIMS access, or perhaps removing PHIMS access if they have left. Again, sending the appropriate form to the service desk. One little tip is in your subject line, when you do send that email, is put PHIMS. Put PHIMS in the subject line. It'll get flagged to that specific group a lot faster. Next slide. Perfect. So maintaining PHIMS access, just to make you all aware, you must log into PHIMS every 90 days or you'll be locked out of the system. To get unlocked, if that is you, you have to call the service desk. And if you're inactive for 180 days, you'll be automatically deactivated, and then your account sponsor or requester does have to submit a new request with the appropriate paperwork. This can take up to 2 weeks. As you can imagine, the service desk has a lot of tickets right now with the upcoming immunization season. So I suggest all staff attempt to log into PHIMS before the busy season occurs and mitigate any problems with access prior to needing it. Go to the next slide, please. Inga had already mentioned about some online training with the new recommended immunizing young children. However, many of you are already aware that there are 2 courses that are mandatory. All 3 courses, if you have an account, are live. You can access them. Once you've been provisioned with PHIMS, you have 4 weeks to be onboarded by the manager and complete the training. So if you are not the manager and you haven't done the training, you can always kind of speak to your manager about that. Should you have any issues, please contact the training team. Their email is posted there, but it's pphtraining@gov.mb.ca. Next slide. The next 2 slides are just the fax reporting forms. We've updated them. Links are here. So pharmacists cannot create clients. So anybody that you have that you can't find in PHIMS or they don't have a PHIN, please fill out this form and send it here to us, and we will get those inputted, as there is the friendly reminder to have everything inputted within 2 working days of giving the immunization. Next slide. And then the other form is the correction form. So anytime there might be an error or anything you see, you can use this form, send it to us, and we will work on that. I would like to point out it's very important to fill out the forms in entirety. This helps us do it right away and lessens any communications we have to send back to you to get the information. Much of this we cannot take over the phone as we are not clinical staff, so it does need to be written and submitted. Please type it so then we can read it easily and submit in a timely manner. And then just speaking of PHIMS, there's a little bit of troubleshooting we can do ourselves, or yourselves, I should say, before contacting the service desk. So one of the most common errors that occurs, and even occurs to me, is you get this target URL not found error. Usually this can be mitigated and fixed just by clearing your browser history. I've put how for both Edge and Chrome onto these slides. And once you have cleared the history, please close the browser and kind of start afresh, and often you can log in successfully after that. Okay. Again, more PHIMS related resources. So phimsmb.ca is a great one. It has those forms for gaining, PHIMS access or the account sponsors or requesters. It explains the difference between sponsors and requesters. That's the question I get quite often. All provincial PHIMS memos are there. And then, as I said before, any training questions, the email is there, and anything you need regarding your information sharing agreements, please contact me. Next slide. Lastly, just the checklist. One more final reminder, make sure your ISA is up to date. Make sure your sponsors and requesters are up to date. Have all staff members log into PHIMS, complete that training, and just ensure you have those new updated fax forms readily available at your sites. And that is it for me.
Thank you so much, Stacy and Inga and team. that concludes the presentation tonight, and I'd like to thank the presenters so much for that presentation this evening. We really appreciate the time and effort that goes into delivering tonight's presentation and for you to providing us the opportunity to hear more about this fall's vaccine campaign. So at this point, we'd like to welcome all pharmacists on the call to type any questions that you have into the chat box. We'll ask our presenters to decide who the best person is to answer the question that you have. It's a pleasure to have a PHIMS member with us this evening. We missed you last year, but we will see if we can do our best to answer the questions that the attendees have this evening. So bear with me as I go to our chat. So I do see that we actually have a chat and we have a Q&A box. So I'm going to see what comes in first. But just to start, there was a comment that was made very early in the presentation this evening that said, I worked in a location that ran out of high dose last year and used regular doses for 65 plus, which might account for why the higher ordering amounts with the high dose vaccine this year. So that was just a comment. We also have a question. Will there be a 2026 spring booster dose as there was in 2025? So Inga, I'm going to point these at you and then maybe you can identify who the best person is to answer those on your team.
So for the spring COVID one, I would say I would go to Richard, but I guess I can say that I would suspect that there would be a spring dose as well. It's still part of the NACI recommendation that goes up to kind of summer of 2026. So if Davinder or Richard thinks anything other than that, then please let me know.
I would agree with Inga. So the exact timing, I think, is still to be determined. So the timing of the waves for COVID has not, there's not a predictability to that yet. So, for example, 2 years ago, things started to increase like around August. Last year, things started to increase around July. And then now this year, things haven't really started to increase at all yet. So, like, we're still not in a predictable pattern, and like the best time for an additional dose or a second annual dose for any of the highest risk groups, that obviously depends on the timing of the waves. So we're still trying to learn as much as we can about the epidemiology of the waves so that we can time any additional dose programs to match that, to have the best benefit. So I expect there will be, but the timing is to be determined.
Great. Thank you, Dr. Singh. There is a question requesting some clarification about who gets Fluzone high dose versus Fluad. I know that you guys have some very comprehensive lists. Is there any opportunity for you to post a link to either where that might appear on a website, or if you want to verbally highlight those differences again, that would be great.
Sure. It might be, I'm wondering if I think we were all we're waiting for the kind of go ahead to post everything online. So this is kind of still, we're in the process of updating our website, but I know I can probably try, maybe what I'll do is I'll put it in the chat. I'll copy and paste the eligibility, and then I'll just put it in the chat, if that might be the best way to go about it. And just so that we can identify clearly what that is, and then obviously they'll have access. But our link, like, we'll have all our eligibility and everything online. I'm just not sure if it's quite there yet. So we're working on it still. But I'll put that in the chat.
Okay, thank you, Inga. So the next question or comment, I believe it's still true that pharmacists can only provide flu and COVID vaccines to children ages 2 and up. Yes. It will be hard for pharmacists to know how to answer the questions about providing vaccines to kids 6 months to 5 years. So the vaccine map information might not be accurate. Inga, maybe you can highlight what it was that you were speaking to with the vaccine map as far as the information that can highlight who's available to administer to children?
Yeah, so the provider map will identify which locations have identified who, if they're going to be immunizing to people who are, you know, 6 months to 2 years or 2 years to under 5. So we'll be able to identify those locations in the provider map. I think the question is actually around the survey, around being able to answer the question for providing vaccines to kids 6 months to 5 years. So I would put your number in there as best you can. And if there's any clarifying information, I think you can put, there's probably a place for comments or whatever, special delivery comments, or you can email us. But I think that's a good question, allows me to see how it's framed again. We might need to spread it out a little bit more in that survey to be able to clearly identify kind of the 5 to 12s and this, because the products are based on the 6 months to 5 and then 5 to 12. Like we go by those products versus what pharmacists can do, right? We have to go by what the product indications are, because other providers can do all the ages. So, we base it on the questions on like the actual product indication. So I think we're trying to figure out what's best way to do that. But definitely if you have concerns or questions about how to best do the order, I would email us at thatvaccines@gov.nb.ca.
Okay. Thank you, Inga. Colin has a question. When will the recording of this presentation be available? I expect it'll only be a day or two, Colin, but we will have it posted on our website as soon as possible, and we will have it shared in likely the weekly script that will come out not tomorrow, but the week after, so it will be quite soon. And then we have a question for offsite clinics. Are there criteria set for cold chain? I'm not sure, Inga, if there's somebody on your team that would like to take that question.
I was trying to cut and paste here. What was the question again around cold chain?
Yes, for offsite clinics,
Oh.
are there criteria set for cold chain?
Yeah, so we have actually a cold chain protocol that is available online. If you want to go to our immunization program manual, we have a cold chain protocol there. And there is a special, there's actually a page that is specific for cold chain maintenance for offsite clinics, like how to do transport. So that is also available online.
Perfect, thank you. And then another question from the same person. Are pharmacists able to enter a historical dose directly into PHIMS if entry is missing and documentation can be confirmed? I'm guessing maybe Stacy might be the best person to answer that one.
Yeah, again, you're only entering doses given at your site. So if you missed one, yes, you can enter it. However, for other sites, please just submit to us. We can do our due diligence on our team and contact the original location to see what happened.
Thank you. Okay. I see a couple of links have been entered into the chat there to help with answering some of those questions. Brittany, your question around will the deck be shared as well? If we will share PDF versions of these slides at request. So if you'd like to receive a copy of the PDF version of the slides, please email info@pharmacistmb.ca and we can send those out for you. I'm just going to flip over to the Q&A section to see if I can see if there's any other questions that have popped in here. Please bear with me for a moment. So I have, there's a question that was duplicated in the chat, but there's a second question or maybe comment around, so I'll just read it as it's been entered here. Administrative burden on pharmacists with PHIMS needs to be considered for a deep review. This includes having a consistent submission process of COVID and flu vaccines on PHIMS versus a different submission process for other publicly funded vaccines. Secondly, the amount of PHIMS audits is excessive and taking pharmacists away from other important work with the public. I'm not sure if Stacy, you have any comments that you want to make around that, or if anybody has any comments they would like to make subsequent to that.
Yeah, I mean, I can take that suggestion back to the team and we can review. In regards to audits, the quality audits are every 5 years per location, with the privacy audits every 3 years, and our team only does ask for submissions outside of the busy immunization season, trying to lessen some of that burden. We won't be contacting any throughout this high season.
Okay, thank you very much, Stacy.
I would say for the other part, we would definitely love to be able to support, all vaccines being put in PHIMS, having like one consistent method. So I think that's something that, whether, something we've definitely been working towards. I think that would be great, and something hopefully in the future we'll be able to be able to do that. It's on our wish list too.
Thank you, Inga. And I know that we've spoken, like Pharmacists Manitoba has spoken to government about that, and it's great to have one option or the other, but like this split system does make things a little bit complicated sometimes, but we can't, not everything can be addressed all at once. So I'm glad to hear from you today that that's also on your radar in the government. Dr. Singh, you have something you want to add?
Yeah, just that it would be great if everything was on PHIMS as kind of the source for immunization for other reasons too, because it has some really neat features like a forecaster. So, I know we're talking about respiratory virus vaccines today, but if we're looking at something else, like let's say HPV vaccines, you can use something like the forecaster if you bring a client up and see that, oh, they're due for their HPV vaccine or something like that. So there's a lot of really neat and useful features of PHIMS that I would hope could be more broadly used. So it's another reason to have PHIMS as potentially the source of immunizations for the future for entry and other things.
I couldn't agree more, and I appreciate hearing some of those other things that maybe as pharmacists we don't see as much. But yes, I agree that having that forecaster and being able to be participating in some of that forecasting is, I think, quite valuable. So just looking at the question and answer, which I'm going to be totally honest, I wasn't expecting to be looking at two different areas to be moderating questions in tonight. I see that we have some questions that are showing up in my screen as answered, but I'm just going to go through these and just make sure that everybody's had a chance to hear the question and see that there's been some answers. So there was a question, why not have vaccine order surveys open Monday to Friday when regular staff are working? And there's been two answers entered in response to that question. And Inga answered, we have to do the allocations and provide the orders to the warehouse for the orders to be entered into the systems. And then they are able to be shipped the start of the next week. And Dr. Baydack, we've got your also comment, the surveys are still open from receipt on Thursdays and Friday, Monday and Tuesday. So 3.5 regular business days in response to that question. Another question that came into the Q&A was, one challenge of pre-order is we were sent a separate email with our 2024 stats for doses given September to October to guide our order decisions. But I was group 2 last year and only received my first order of COVID-19 and flu vaccine on October 22nd. So I only gave vaccines for 9 days in September and October, whereas this year I am group 1 and I expect to have many more days in October to administer vaccines. So it looks like I'm ordering more than I need this year. Inga's response was, if you're concerned, I would suggest emailing us at vaccines@gov.mb.ca to explain this. Next question was, once vaccine is received, can we use it same day as long as that cold chain is good, correct? Versus we don't need to hold the vaccine for 3 days prior to using it. And Inga's response was, if you're in the city, then yes. For rural, there would be temperature monitoring devices that would need to be reviewed. The instructions that would be included with the shipment. There are instructions that would be included with the shipment. My apologies. Another question that came through. Last year, we received all flu shots in the first delivery of Survey A and then COVID doses in the second delivery 2 weeks later. Based on the dates you were receiving stock from the feds, it seems like we will get a mix of flu and COVID with the first deliveries. Is this correct? And Inga, thank you. Your response is that is the hope. I think we're all crossing our fingers on that one.
It is expected, but you never know.
Right. Okay. There was another question that says, will you be identifying what residences/buildings are classified as assisted living/supportive housing? I.e., will a list of senior congregate living addresses be available as a reference? And Inga responded, we don't have a listing, but it would be congregate living facilities where seniors may have common areas and are a managed facility, i.e. not just an apartment block with many seniors. Next question in the Q&A. I expect to be fielding many questions from 65 to 79-year-old patients who have previously received Fluzone high dose, but will now receive Fluad adjuvanted. I anticipate some concern that if it's not high dose, it's inferior. What talking points will assure these patients they are getting an effective vaccine? Have there been any head-to-head studies of Fluzone high dose and Fluad adjuvanted? Inga's response, there has not been any head-to-head studies. We will have the fact sheets for enhanced vaccines for seniors that will be available. Not sure if it's online yet. I will also ask Dr. Singh to provide more information on this. So maybe I'll just pause for a moment instead of me droning on to see if Dr. Singh has anything to add to that. Please go ahead, Dr. Singh.
Great, thanks. Yeah, so it's a very good question. I expect a lot of people will ask it. A lot of you may get this question this season. So, I think that there's a few important things to note. One, the National Advisory Committee on Immunization specifically, doesn't recommend any of the enhanced products over the other. There's actually 3, but only 2 are available in Canada. There's not enough evidence to recommend one product over the other, and there haven't been any studies that like high quality studies with enough power to really answer the question, is either of them better than the other? There's substantial body of evidence that indicates that both products seem to be better than standard dose, and there's a greater body of evidence that the high dose product is superior to standard dose, but the available evidence for the adjuvanted product also indicates that it's better than the standard dose. So they just employ two different strategies to boost the immune response in an older person. The high dose uses 4 times the antigen as their strategy. So instead of 15 micrograms, there's 60 micrograms of the antigen in the product, and then the adjuvanted product uses an adjuvant as their strategy to boost the immune response, which is another well known and common strategy overall. It uses a specific adjuvant, MF59, but there's lots of other vaccines that use different adjuvants, like Shingrix, for example, is a common vaccine that uses specific different adjuvant, and the reason why it works so well is probably because the adjuvant creates such a strong immune response. So really, I would hope, without droning on too long like I have, that you can try to let the patients or clients know that we have maybe a greater body of evidence for one, which is why we prioritize it for the people that we think are at the highest risk, but both are superior to the standard dose, and NACI doesn't recommend one over the other because there's not any head-to-head evidence that's available to suggest that one's superior to the other.
Thank you for providing that explanation.
That's why I left it for him.
That's great. No, much appreciated. Couple more questions in the Q&A, and then I'm going to flip back to the chat. So while the Manitoba Health memo mentions that frozen COVID-19 vaccine is not available, only thawed product, staff have reported that the naming of the product in the survey suggests that the frozen product can be ordered. Could you please clarify this? Inga's responded, if you want your order sent to you frozen to be placed in the freezer, you can request that in the special delivery comments. I'm not sure what is meant by the survey suggested the frozen product can be ordered. So if there's any further questions from the anonymous attendee who entered that question, please pop that in the chat and we can circle back to that question. Amanda put a question in the Q&A. Are pharmacists able to use the correction form when we see errors on the client's historic immunization record? Thank you, Stacy, for answering. And she says, yes, you could submit the correction form. Please clearly state that it was given at another location. Our team will do our due diligence and contact the location for corrections or clarifications. Alternatively, you can direct clients to our online order e-form to submit a request regarding an error. Furthermore, same person has entered that we entered incorrectly at another location other than our own.
I think that was just a continuation of the same question.
Okay.
And just to clarify, directing clients to the e-form can be used for a multitude of things. Either correction, missing info, if they have an out of province or out of country submission of an immunization record, all that can be done there. Or even if they want a copy of their immunization record, which you guys are allowed to print, but for whatever reason, if you can't that day, you can direct them to that e-form.
Perfect. Okay. Thank you, Stacy. And then the last question in the Q&A before I pop back to the chat. What's the time frame for how long it will take for a new PHIMS user to get access? In brackets, I sent a request last week for a new employee. Stacy has answered, it can take up to 2 weeks. Please ensure you use the word PHIMS in the email subject line. So I've heard that a couple of times. We'll emphasize, please use PHIMS in the email subject line. Okay, I'm going back to the chat function here. So bear with me for a moment as I try to find what the last question was in here.
You'll want to start at Kimberly Thiessen.
Okay. I actually, before that, I see a question around, please clarify. You said we are able to print immunization records, but I'm afraid I don't know what that was in relation to as far as the questions go. So maybe I'll just take that as a brand new question. So
yeah, Stacy had just mentioned about printing immunization records, so I'm wondering if I came in right after that. So I knew I was hoping someone was going to, because we still get people requesting us to print them for them. So yes, you are able to print immunization records as needed for clients or whatever, or for someone that comes in and asks, you definitely can print. It's part of, I think it's included within the ISA.
It is.
As well. Yeah.
Yes. I know that I get many questions around that. The original ISAs, when we first started only COVID, you weren't allowed to print. With the new, with COVID and flu, you are allowed to print records for clients.
Thank you very much. Okay. And then Kimberly Thiessen has asked, will there be increased availability of Prevnar this season?
We've definitely ordered more this year to accommodate compared to what we had available last year. So there should be, as long as, it's definitely to make sure. I think last year there was a lot of doses being administered when they weren't supposed to be administered, but we definitely are able to accommodate a larger load this year for sure.
Great. Thank you, Inga. I think we're caught up on the chat and the Q&A. There is a question in the Q&A around the availability of pneumo vaccine compared to last year. So you've just answered that. So I don't see anything else new coming up in the comments. I do see that there is a hand raised. So Gail, please go ahead and ask your question if you'd like. Are you able to unmute yourself, Gail, or do I need to? I'm going to try to unmute.
I see Gail in the attendees anymore, so maybe she had to pop out, but it's odd that her hand's still raised, but
I see her in the attendees still.
Oh, no questions. She's put in the chat.
Oh, okay.
And just say she is here, not driving a bus at Gail.
All right. I'm not seeing any other questions. Any other, oh, maybe there's the Q&A. Nope. I think that takes care of all of the questions for this evening. I'll just give it maybe another 30 seconds or so if there's any other questions. Oh, I see one other question coming in as well. So Colin is asking if you can quickly go over something. We'll wait for him to finish typing his question. And again, thank you so much for everybody here who's been presenting for us this evening. Your expertise and knowledge about this program and everything that's going to roll out over the next several months is much appreciated. Okay, so Colin's question is, can you quickly go over again the congregate living facility eligibility for flu zone high dose?
I'm not sure if there was somebody, like, I don't know, if Richard, if you're available. I did put our eligibility up in the chat if you can find it. I couldn't get the bullet points and bullets all pretty and everything, but I think congregate living to me is that I think we have to figure out really what that means. Right now we have it as residents of long-term care facilities, including residents of supported and assisted living facilities. So I'm not sure how that's different than congregate living, but I think we need to, I guess, figure that out. In my mind, I would say, there's the facility, the different levels, and if they're in a facility where it's being managed, they have common eating and living areas, that would be considered a congregate living setting, but I'm not sure if anybody else, but I also don't, like, my mother's just in a regular apartment that has lots of seniors, so I wouldn't consider that to be, I think it's a specific setting. So I don't know if Davinder or Richard has any thoughts on that.
So I can give it a try. I've been booted out of the meeting, I think, about 6 times. So I'm just a little leery of that. I think it's like the key is there are supports and it's assisted living. It's not just any location where many seniors are living. So I would focus less on the word congregate and more on the word supportive or assisted. aside from long-term care. I don't know if that helps.
Yes, I do believe that that helps. Thank you very much, Richard. Okay, I think we're at the last call for questions this evening. Oh, I have one other question come in the Q&A. So one challenge of pre-orders is we were sent a separate email with our 2024 stats for doses given in September or October to guide our decisions, ordering decisions. But I was in group 2 last year and only received my first order of COVID-19 and flu vaccine on October 22nd. So it only gave vaccine for 9 days. This is interesting because it's a very similar question that was asked earlier.
I think it's the same one. I think it's the same
It
one.
actually might be the same question.
Yeah.
My Q&A has gone right back up to the top. Look at that. So my apologies. All right, then I don't see anything else new there. And I just want to say again, thank you so much for all of our panelists who have joined us this evening to provide our presentation, give us a little bit of insight about what to expect this year, and help us prepare for a busy upcoming season. And thank you to everybody who joined us. And as mentioned, we will have a link to this presentation available on our website shortly. We will also circulate it in our weekly script. And if you're interested in a PDF version of the slides, we will send those out as requested. Please email us at info@pharmacist.mb. Sorry, info@pharmacistmb.ca. And with that, I guess we'll say good evening and hope everybody enjoys the rest of their week. Thank you and have a good night.